Hello, my name is Kristian Steen Frederiksen, and I'm a consultant neurologist and director of the clinical trial unit at the Danish Dementia Research Center. I'd like to start by thanking the organizing committee for inviting me to give this talk at this conference on the effects of physical exercise in Alzheimer's disease and looking at the effects and possible underlying mechanisms. So I'll start briefly by giving an overview of the possible background for why exercise might affect the brain. Then I'll move on to talk about specifically Alzheimer's disease and the effects and possible underlying mechanisms, and then reaching a conclusion. I'd like to start by taking a bit of an evolutionary perspective on exercise and the brain. Now, of course, we've evolved from the apes and undergone a myriad of different changes, two of which I will touch upon. Firstly, we've evolved to a less muscular build, and this has meant that the amount of energy that is consumed by muscles have gone down from our ancestors, the apes, to now modern man. In parallel with this, we have evolved into having a bigger brain, which also consumes a larger proportion of the energy. And this shift from energy consumption from the muscles to the brain has enabled the development of this larger brain, but also clearly demonstrates that evolutionarily muscle and exercise and the brain have evolved in tandem. This also goes to some lengths to explain why being physically active is associated with, that a sedentary lifestyle is associated with a number of negative health outcomes, no least of which is dementia. Moving on to Alzheimer's disease, I'm going to be reporting some results from a study we did at my center some years ago called the ADEX study, looking at the effects and underlying mechanisms of aerobic exercise in Alzheimer's disease. I'll be reporting results on cognitive function, activities of daily living, and neuropsychiatric symptoms in patients with Alzheimer's disease. The ADEX study was a randomized controlled trial in which we included patients with Alzheimer's disease with an MMSE of 20 or above, so relatively early and with a mild disease. Patients were either randomized to usual care or usual care and aerobic exercise intervention. The aerobic exercise intervention consisted of 16 weeks of 3 weekly sessions of 1 hour each of aerobic exercise, where we aimed at the participants exercising at around 80% of their maximal heart rate. And we monitored the heart rate, and this was also group sessions, which was supervised by a physical therapist. We assessed a total of 608 patients for inclusion and included a total of 200 patients across 7 centers, and participants were randomized to one of the 2 groups. A total of 190 patients completed the study. So these are just some baseline demographics of the patients. I'm not going to go too much into detail with this, just to say that there were no significant differences in any of the demographic or comorbidities at baseline between the 2 groups, and then to say that this is a group of relatively mildly affected patients with Alzheimer's disease, as indicated by the MMSE, which was around a mean of 24 in each group, and also that patients had relatively few neuropsychiatric symptoms, as indicated by a mean score of around 10 points on the neuropsychiatric inventory in both groups. Patients were assessed both at baseline and after 16 weeks of aerobic exercise. All patients underwent blood sampling, assessment of cognition, physical fitness, and aerobic fitness, and neuropsychiatric symptoms, and we also had questionnaires on quality of life. It's also important just to say that following the 16 weeks intervention, patients in the usual care group were also allocated to a smaller 4-week intervention of aerobic exercise, so that we also were able to offer these patients some degree of training. Specifically with regards to the outcome measures that we looked on, I'm not going to go through all of them, but just for just highlighting some of the most important ones. For cognition, we used the simple digit modalities test, the SDMT, as the primary endpoint for the whole study. This is a measure of processing speed. We also assessed general cognition with MMC and memory with the ADAS-Cog recall test. For physical fitness, we looked at a number of physical tests, such as the timed up and go, hand grip strength, and walking test, as well as assessment of VO2 max. That is the amount of oxygen that the muscle can metabolize per weight of muscle. We also used some questionnaires to assess physical fitness, such as the physical activity scale in the elderly, or the PACE. And for neuropsychiatric symptoms, we used the neuropsychiatric inventory and the Hamilton depression scale. We also had a subgroup of a sub-study in which around 70 patients were included, and these participants underwent MRI, amyloid PET for assessment of brain amyloid, and lumbar puncture at baseline and 16 weeks follow-up. So these are the results from the ADEX study, looking at cognitive function, and at the top here you will see the results of the intention to treat population, so the intention to treat analysis. And here we did not find an effect on the primary outcome measure, the SDMT. We did do per protocol analysis of high exercises, so that would be those participants who participated in 2 out of 3 offered exercise sessions. And here we did find a significant effect on the simple digit modalities test in favor of the aerobic exercise intervention. Now, this is in line with a number of other studies that have looked at cognition in Alzheimer's disease, and this is results from a meta-analysis showing a beneficial effect also across a number of trials on with regards to physical exercise in Alzheimer's disease. This is another meta-analysis looking a bit more specifically on different cognitive domains, and there's the most clearly effect on global cognitive function, followed by executive function, and lastly by memory function, indicating that perhaps there is some sort of differential effects of physical exercise on cognitive functions, in that functions such as executive function and processing speed, which are observed by frontal areas, might be more amenable to physical exercise, and I'll just come back to that later on. We also looked at activities of daily living, and we did not find any effect of the intervention in the ADEX study, but others have found that physical exercise might be able to improve activities of daily living. This is a meta-analysis showing that at least for some outcome measures, there is a significant effect also in patients with dementia. And lastly, we looked at neuropsychiatric function or symptoms. And here we did find an effect of the intervention on the neuropsychiatric inventory, both in the intention to treat analysis as well as in the per protocol analysis looking at the high exercises. And here we found that patients who were in the aerobic exercise intervention group had a decrease relative to those that were in the usual care group of around 3.5 points on the NPI. And I think it's important really to keep in mind here that we did have a group with very few neuropsychiatric symptoms, a mean of 10 points on the neuropsychiatric symptoms scale, so quite a significant reduction in their neuropsychiatric symptoms. This is a breakdown of the effects on different domains on the neuropsychiatric inventory, and we see across a number of different domains that there was an effect. The most clear effect was on agitation and aggression, but also other domains. So moving on to underlying mechanisms, and I will just touch upon two possible underlying mechanisms in Alzheimer's disease, and that's brain volume and hippocampal volume, and beta amyloid and tau. This is just a very seminal study from 2011 by Erickson and colleagues looking at 120 older adults, so not patients with dementia, who underwent an intervention of walking 3 times daily, and they reported a quite profound effect on hippocampal volume following this exercise intervention, and that has really stimulated a lot of research. Unfortunately, subsequent studies in a variety of different populations, not only dementia populations, have failed to find a similar effect as indicated by these two meta-analyses. This one, as well as the next one, looking at both region of interest analysis of MRI studies or voxel-based analyses. We also looked at the hippocampal and cortical thickness in the ADIC study, and we were not able to demonstrate any effect in the hippocampus, but we did find that there was a correlation between change in cortical thickness in frontal areas and change in physical fitness as measured by VO2 max, indicating that frontal areas seems to be more amenable to physical exercise in Alzheimer's disease. We also looked at beta amyloid, a hallmark, a pathological hallmark of Alzheimer's disease, and we did not find an effect on beta amyloid. I just want to highlight these very interesting results from a relatively recent study looking at beta amyloid in a preclinical Alzheimer population, so in patients with beta amyloid deposition, pathological levels of beta amyloid deposition in the brain, but no symptoms, and a year intervention, aerobic exercise intervention, and they were also not able to demonstrate an effect on amyloid. So what conclusions can be drawn from the findings in the ADIC study and other studies? Well, I think it's safe to say that exercise is definitely beneficial for the brain and for brain health, and it also quite convincingly affects symptoms of Alzheimer's disease in a positive direction, both with regards to cognitive function and neuropsychiatric symptoms. Underlying mechanisms remains uncertain, and I think that the long-held belief that aerobic exercise might affect hippocampal volume is not really very clearly grounded in the literature at the present moment. We lack very much studies in Alzheimer's disease, both with regards to looking at clinical outcome measures, but also with regards to studies looking at underlying mechanisms such as effects on hippocampal volume or other brain volumes, or indeed other pathological hallmarks of Alzheimer's disease. So with these concluding remarks, I'd like to thank you all for your attention, and I hope you have a great conference.